So the Chairs Symposium of the ECE in Vienna was around status epilepticus and the recent developments. And we had some outstanding talks, all of them bringing new data about the pathophysiology and the understanding of the mechanisms of status epilepticus. It's not just a longer seizure, this is what we know, but how can we detangle the mechanism and how does status epilepticus propagate? Jaideep, can you comment about that?
So I think there is an exciting opportunity to understand spread of seizures and why seizures become longer and longer during status epilepticus with new mouse models and new techniques, both in imaging the brain and also in doing very sophisticated electrophysiology where we can actually look at the activity of ensemble of neurons, and hopefully the new insights that are emerging from these mouse models will inform treatment of status epilepticus in the future.
There are so many changes going on with status epilepticus, and every month or every half a year there are new data. And one of the things it's very difficult to understand for me how these epigenetic changes of status epilepticus can be influenced on a short-term basis if we think on acute treatments. David, could you comment on that?
So epigenetic processes really influence whether or not genes can be turned on or turned off in the first place. And in the past, they've been thought of as these very long-term switches, which are sort of set in place very early during brain development and other organisms, and that they remain stuck in that on-off situation indefinitely. But what we've learned is that certain types of injury to the brain and status epilepticus will produce changes to these gene switches, which can mean that you can end up turning on genes that would normally be switched off in the brain and switching off genes that would normally be turned on in the brain. And what we think is that if we could learn a little bit more about how these switches are controlled, we could come up with some new therapeutic targets. So ways to maintain a gene which would be getting switched off in the brain following status epilepticus, or switching back on something that status epilepticus had caused to be turned off. And whether or not this can be beneficial for acute anticonvulsive treatment is uncertain, I think, at this point. Although, of course, we're at such an early stage, we don't know what we might discover. But certainly you could see applications around neuroprotection or interfering with some of the disease development outcomes following status epilepticus, including, of course, the development of recurrent seizures in the future.
So this would open up for protection and preventing the long-term consequences which we very often see after status epilepticus in terms of cognition or neuronal development. What about the new acute treatment of status epilepticus? Is there anything new coming up where you have promises, Stefan?
Yes, I'm pretty confident that we will see new and efficient drugs, but I have really to underscore the two precedent speakers, because if we better understand how status epilepticus continues or a seizure doesn't stop and how we can treat the influencers, then we will have better medications. There are some new medications at the horizon. I'm pretty confident that they add some substantial benefit, and for me it's also a question whether we should not make very early combinations of different drugs, giving the whole shot at one time and then shut down the status epilepticus.
When we think about all these mechanisms, the epigenetic changes, the seizure spread, the influence on the neuronal development, the consequences, do you really believe that one drug would fit all purposes that we wish, especially if we think on the developing brain and the completely different mechanisms in neonatal status? Ronit.
Thank you. I don't think the mechanisms are per se so different. I think the neonatal brain is particularly vulnerable, and some of the mechanisms are immature, but the same drugs. I mean, phenobarbital is also used or has been used in the past for adults, but nowadays it's not, and there has been so much development. Neonatal seizures and neonatal status has been so neglected over the last, until now really, and it's only now that we look at in more detail how we diagnose them and how we can treat them. So I think we are still, as you said, 10 years behind, and we have to do some catching up. Particularly with the treatment.
So there's a lot of things to do, but the future looks bright because the understanding really grows and grows. And I think we have to set priorities, what to do and what to follow next in this very exciting and fastly moving field. Thank you very much. Thank you all for participating and giving so excellent talks. Really appreciate it. Thank you.